Introduce our first speaker today, and that is Nathan Lee. Nathan is the Data Officer and GDP Task Force Leader at the European Institute for Innovation through Health Data, and he's also a Senior Research Associate at the UCL Institute of Health Informatics. So Nathan, I'll hand over to you now.
Many thanks indeed. First of all, you can see my presentation, can't you? I always do this check nowadays. It's all coming through okay, isn't it?
Yes, we see it. Thank you.
Excellent, and you can hear me too clearly. So I think we've ticked those boxes. Good morning, everyone. It's my pleasure to address you all at this webinar today. I recall we were going to do this back in April, face to face, but unfortunately that couldn't happen. So I'm so pleased that we're able to, through the power and magic of technology, have this session now instead. So as the introduction indicates, I'm work for IHD, the European Institute for Innovation through Health Data. For those of you who don't know it, we're a not-for-profit organization that is aiming very carefully to promote the enhancement of health outcomes and healthcare through the effective, secure and trustworthy use of health data. So that's quite a broad agenda, but an important one. We work with agencies, companies, public authorities all across Europe and sometimes beyond. And our main goal is to achieve those objectives. We also work on a number of innovative medicine institute projects and EIT projects as well to try and bring to realization the goals that Jolene has outlined in her introductory slides. So I thought I'd start off with something visual because my expertise is in software, engineering and information governance. So these can be very dry topics. So I like to bring something visual every time I talk about these areas. And I thought I'd steal from Magritte, in fact, that the very nature of what we're trying to achieve cannot possibly be a silo. So it's a little bit less enigmatic than the PEEP painting, but what we're dealing with here are not only basically what are ostensibly silos of information. We're dealing with networks in effect and the ability to transfer data and use it across a variety of different purposes that we'll explore this morning. So the very nature of what we're trying to achieve here, particularly with personalized medicine, abhors silos. So let's see if we can make some progress in tackling them because they still exist. So just to give a brief nod to my other areas of engagement, I work with UCL and the NHS in information governance, broadly speaking, to try and make sure that we can allow data to flow effectively across the UK and internationally with our research projects. So I also lead on governance for approving a lot of studies and making sure they're secure and reuses of data. So what I say to you today has that background infused in this as well, that experience. So I will talk to a few examples there too. So moving forward, let's set the scene a little bit. No one can deny that in the late 80s, when I think it was the Mayo Clinic that first pioneered anything that remotely resembled a digital record, there's been huge advancements in digital provision within the health sector and more generally. So things that we could only imagine or not even imagine 20, 30, 40 years ago are now just normal. We're walking around with supercomputers in our pockets with our smartphones, and we're engaging over high-speed networks with people in ways we never thought possible. And that has huge advantages, but also concerns about security and so forth. But within the health sector, this is a particularly complex area. Deployment of digital provision all across Europe, all across the world, is not consistent. As much as we may have large-scale electronic healthcare record systems in place to capture data about care and also to reuse it, not all hospitals, not all GP practices, and not all affiliates have that provision. Some are still working with paper. So there's an inconsistency there that we have to bear in mind. And we're resolving it, but slowly. And we have to remember that technology brings enormous culture change as well. So there are complexities we have to address. But as much as since I started working in this area 20 years ago now, I'm frightened to say, we are starting to realize the promise of EHR systems at scale. So reusable data with some degree of assurance that it's representative and accurate, though there's still concerns there and there are still challenges. But unfortunately, we are still being stifled by what I would call a silo mentality. In effect, there are areas that we need to address specifically, but I think we've had a very good exposure between all our collective expertise as to what works and what doesn't. What does work are networks and interoperability when they are deployed properly. What doesn't work is a silo mentality. So if we look at this in detail, this is what I like to call the data lifestyle and health innovation. It's very similar to what you may have heard of as a learning health system in effect, which is an exciting area and has become more than a prospect, is now actually being used for real. But this involves much more of the focus on how the data is flowing. Now, as an information governance expert, I always like to focus on the individual and the duty of confidence. But generally speaking, we need to follow the data and where it's going, where it needs to go, where it may not be going, and where it is going, where it shouldn't be. So we need to make sure that things are more secure. But we commence here where you've got data acquisition at the point of care. Most of the health data we're using, but by no means all of it, is captured during the confidential therapeutic relationship. And this is variation across Europe, but the consistency is there. The medical profession has a duty of confidence and secrecy. So a lot of data is gathered from patients as they walk in the door by their clinicians, their doctors, their nurses, their care team, but data flows to other members of providing a health service, like pharmacists for prescribing medications, like hematologists and phlebotomists for drawing blood and analyzing it. And there's a huge focus on genetic medicine as well, and genomics for the personalized element. So it's a family of experts that are actually part of the care relationship. And there's a lot of different kinds of data, as I'm sure we're all aware, that comes together. Now, what is happening in a fair degree of cases, but not, like I said, not all, is that these are increasingly being stored, these records, within the HR system. And that has a great deal of reuse potential, as we are realizing. So hospitals need to look at how well they're delivering a service. They need to commission services. They need to bill and fund their efforts. And they need to contribute to public health surveillance. So we've seen how important this is with the recent coronavirus pandemic that is still ongoing, the importance of public health data that is rich to inform policy and decision making. But it's not just about what's captured in hospital or GP practices, as we've seen with the various contact tracing.
Nathan, you're unmuted.
I'm so sorry. I don't know how that happened. My apologies. That just happened randomly. Thank you for that. So I'll start back from the use of data for service evaluations and audits. So we need to know how well hospital and GP services are working. We also need to audit what happens whether things are working well or whether they're not working well, if something has gone wrong. But the really exciting but also complex area is the reuse of the data for the research side of it. So this is not about delivering care. This is very much about improving care and outcomes for individuals. So you have many different kinds of research where this is pertinent. Some of it's specific for specific disease areas and outcomes for a smaller cohort of individuals. So looking at disease areas like diabetes, like HIV, like dementia, it's on population scale. But given the sheer volume of data that we're looking at, there's even more that's happening with regards population level data processing. We also have data use for health innovation in broad terms. So this is where you could have some of the more traditional clinical trials for medicines and devices, but also where you might be looking at new paradigms for conducting the research. But what we also have is the data processing need for building capacity and enhancing how we do things. And I would say that things like the omics research area and machine learning and artificial intelligence fall under this category, because we're now starting to be able to build neural networks and machine learning systems that can start to, perhaps in some cases, diagnose things better than humans and make better recommendations. So that's where you do need data at scale to be able to be representative and accurate. So the excitement is there, the potential is there. And as you can see from this blue arrow coming back to the individual, they are empowered to manage their own healthcare through the use of digital technology and mobile devices, but it makes the relationship with their healthcare providers much more rich and meaningful. So this is an important area that we have to bear in mind moving forward. However, here we come with the silos. Now, I'm putting up there the regulatory frameworks, and we've had a lot of upheaval in terms of regulation. Some of it, most of it, I argue, good. I think it's been helpful. So with the advent of the General Data Protection Regulation, everyone who's handling personal data, including the healthcare sector, is looking very carefully at how they handle it. So in broad terms, GDPR is a common sense law about data protection, and it's got all the right things in there. It's encouraging people to make sure that data is accurate, it's up to date, it's transparently used, so data subjects know what you're doing with the data, it's secure, and you're accountable for it. And it also reinforces the rights of individuals as well. Now, that, of course, requires interpretation, not only at a member state level and international examples where GDPR is being applied, say, where there are provisions in Canada, in Indonesia, Australia, and a host of others that are actually looking at this as a good idea, but also across member states. And even then, individual institutions have to interpret things themselves. So as we look around this area, I'm taking the UK as an example. It's an important example because we are actually 4 jurisdictions in the UK. There's England, Scotland, Wales, and Northern Ireland, as well as the some of the island representatives as well for the Shetlands, the Isle of Man, and so forth. So we're quite a devolved country in effect. So when I talk about things like HSC CA 2012, that's the Health and Social Care Act. It only really applies in England and Wales. And this is about the use of data and the reporting requirements, as well as the health provision that's specific to England and not Scotland. So there's already variation. So you have things like the Care Act as well around research and ethics and providing care. Again, only Scotland and only England and Wales, not Scotland and Northern Ireland. So there are several different variations already. And you also have different interpretations with regard to ethics and some of the practicalities for implementation. So these can breed silos in effect. One healthcare trust in one nation will look at things differently than another by definition, because the laws are different. And the trouble is when you want to interoperate and you actually have to share data, that's when you have the real challenges. And it's very easy to say, we can't understand the law in this area, we're not going to share the data. It's insecure, there's a risk. So these are areas that I want you to bear in mind moving forward. So interpretation of regulation can breed silos. And it's important to take a step back, a deep breath, and figure out what you're actually doing with the data and who's involved as to begin with. So moving forward, the other traditional silo area is the use of technology and ICT. So what I've got here are a host of different vendors and so forth, but also standards. So the EHR world is populated by about 7 different standards. And I think the ones we're almost familiar with are ones like HL7, OpenEHR, and EN ISO 13606, which is an interoperability standard. So different healthcare providers will purchase systems that have different standards that they're based upon, and you have to be able to interoperate. So an OpenEHR server needs to share data with an HL7 server, for example. HL7's been developing its SAPHIRe service for interoperability, so you've got some traction there. But even within specific healthcare enterprises, one system may be OpenEHR, another might be HL7. So a great deal of effort needs to go in to make sure that data can be shared effectively and interoperably. But then as we look around at the different reuses, there are different target technologies and analysis tools that are being used. Some use things like Stata for statistical analysis. Some are programming things in R and Python. As we look into the enhancement area, you have various different technologies as well, whether it's Sparkle or the use of RedCat for ECRFs, or whether we're just using good old CSVs and plugging it all into Microsoft Azure Cloud that's secure. And you can see things like safe havens and secure access and so forth on this diagram. Because of the research reuse component and potentially the higher risk of granting access to a wider group other than healthcare and patients, healthcare professionals and patients, we have yet more complexity heaped upon this, where we have to be very careful about how data is shared. But we do have to make sure that the different technologies we use are able to represent the data accurately, but in a timely manner as well and securely. So all these different siloed components need to interoperate. They need to work together as part of a network. So to summarize, here are the repeat offenders for siloing. There's often the excuse that technology won't work together. We obey different standards. It can't interoperate. The rebuttal to that is keep an open mind. It's clearly not the case where large-scale EHR standards groups have got huge provision for interoperability, as well as increasing guidance on how to implement this in practice. We also have things like HOMOP that are very effective at taking a database snapshot and providing a reliable research data set specific to the context. And that's working so much better as a means of providing that view on the data in addition to the ability to share that data effectively. But don't be too wedded to one tool or one creed when it comes down to it, because these things were built to work together. This was about de-siloing. And whether you prefer to use R hand-coded for your analyses or Stata or one of the other statistical packages, all these things require everyone to know what they're doing with the data and be able to use them. So when you hear regulation forbids it as an excuse, the rebuttal is, in fact, regulation demands it. Now, I could cite a host of regulatory examples, not just from the UK, but elsewhere. But the important one is GDPR, where the recitals are very clear about the importance of making sure that data flows in effect. So that is the primary purpose here. But
No i zadamy też teraz, już skończyłeś lekcję, czy jeszcze masz jeden?
Excellent. So on that note, so that was just a reminder to me that I must wrap up. I'm going to leave it there. I'm hoping this talk sets a good foundation for our discussions this morning. We do have challenges, but I think with a more harmonious view of how we address them and actually looking at what technology and regulation is actually offering us, we can use it effectively. Thank you very much.
Thank you, Nate.